get ready to take control of your healthcare. Here's your host, Ray Cobra.
And we're live, ladies and gentlemen. Welcome to Broken Healthcare. My name is Ray Cobra. I am your host, and I am joined today by Rosalie Faris. And welcome, Rosalie.
Thank you very much.
Excellent. So our paths crossed at a recent conference back in September at Health Rosetta. What were you doing there?
Well, I was asked to speak to talk about the advantage of utilizing a combination of direct primary care and navigation, using nurse navigation, and bundled healthcare services.
Wow, that's a mouthful. So
Yes, it is.
how did it go? Do you speak often?
I do. Most of the time I'm speaking on workers' compensation topics, but I also do speaking on group health topics. But this was pretty good. I was the rose between two thorns. I had a doctor to the left of me and a doctor to the right of me, and I was the nurse in the middle.
Ah, so you're also a nurse.
Yes.
You do tell. So how did you get into nursing? What was your, and by the way, thank you for your service. I don't think it's said enough, but nursing is God's work. It's really tough work. We need our nurses. I believe there's a national shortage of nurses, and often I think it's a very thankless profession, but amazing work that you do out there, caring for your fellow brothers and sisters. So thank you for that. When did you get started? When did you know that you wanted to be a nurse?
In high school.
Really?
I came straight out of high school, and then I was lucky enough, one of the hospitals in town offered a scholarship to go to nursing school, and it was a 2-year program, and I had to agree to work for them for 2 years. And so as soon as I got out of school, I went straight to work for them, and I was there for more than 2 years. It was closer to 15 years
Oh,
before
wow.
I left them. But and I worked everywhere from the ER to the OR to the only place I didn't work was OB. I swore off babies. I didn't like to do the baby thing, but everything else I did. And then I ended up doing, my last stint there was doing occupational medicine.
Huh. Yeah, that's funny. I guess to each their own, right? I'm sure you had colleagues that loved nothing more than the babies.
Oh, yeah.
And it wasn't your cup of tea, though. It was
Nope, no,
you.
not my cup of tea.
Huh.
I like
Wow.
patients that could talk back to me.
A little feedback loop.
Yes.
Good stuff. So fast forward then and take us to your departure. What was your next step after working, out of college, out of nursing school into this position that was supposed to be 2 years? It was 15 years, a little longer than you intended. Where'd you go from there?
Well, I left there and came to work for a gentleman that was working in the workers' compensation area. And we developed a medical management company for workers' compensation, and we did bill review, and that's OMCA, Occupational Managed Care Alliance. And that business is still in place. And then out of that, we found that if we could do case management and medical management for work comp and utilization review, then there was a position to do that in the self-insured group health space. So then we kind of morphed into that. And Occupational Managed Care Alliance didn't really match that. That brand didn't really match doing what we were doing in the group health side. So we started a company called Medical Review, and then that's where MediReview branched out of. So that's like the brand name for our group health UR case management, medical management program.
And so tell us exactly what is medical management. I think, for the layperson out there, they know that they have an insurance ID card in their pocket, and that's their access to healthcare, and everything is kind of done for them. Is medical management something that takes place in a fully insured plan that most people are familiar with? Or is this something that is really only available if your employer has got a self-funded plan?
The BUCAs do some medical management, but their medical management, I believe, is more aimed at saving money. And I think on the group health side of a self-insured employer, the medical management is more at assisting the member to navigate a very complex system. I mean, the medical system is not an easy system to navigate. And if you're not familiar with it, you have no idea what to do if you need something. So in our space, what our nurses do, we kind of sit in the middle and we become the communicator and the interpreter. Because if I can give you an example, when I was working in the hospital, I was rounding with the patient, with the doctor, and talking to a patient, and the doctor said to the patient, you've got scoliosis. And he didn't explain what scoliosis was. And when he left the room, I looked at the patient and she was sobbing.
Oh
And I
God.
said, why are you crying? What's going on? She said, he said I had multiple sclerosis. I said, oh, honey, that's not what he said at all. You've got a curvature of your spine. It's no big deal. Let me get him to come back in here and explain it. So what the patient hears is not necessarily what the doctor says.
Yeah.
So we want to make sure that what the member hears is what the doctor says. We want to make sure that they are compliant with taking their medication. We have patients sometimes that go home from the hospital and they get nauseated taking their antibiotics, so they just stop it.
Yeah.
Well, let's call the doctor. Let's see if they can give you another antibiotic. So we want to sit there in the middle and make sure that they're getting the care they need and that they're following up the way they're supposed to. We want to make sure they're compliant with their medication. We also do utilization review. We're making sure that the doctor is doing what they need to be doing so the patient's getting the care they need. But we want to make sure that the doctor's not making money off the body of the patient. In our workers' compensation system, we have a problem with that. And I'm from Kentucky. In Kentucky, nobody did opioids like Kentucky did opioids.
Hmm.
And we got to the point where, even our administrative law judges and our commissioners said, we've got doctors in Eastern Kentucky that's making a living off the injured worker's body, because they would say to the injured worker, well, we're not going to give you your opioids if you don't let us inject your back.
Huh.
So we want to protect the patient from overutilization of unnecessary tests and procedures, but we also want to make sure that if they need something, that we expedite it so they can get it quickly and they can get it very cost effectively, because everybody has a very high deductible nowadays. And if we can step in there and we can find a lower cost place for them to get that procedure done, and some plans, we have plans that right in there, if the member is agreeing to go to the low cost facility that is still high quality, that they will waive the member's copay and deductible. Well, lots of people don't get a $5,000 test when they have to pay the first $2,000 of it.
Sure. Yeah, no, money doesn't grow on trees. And statistically, we know that most Americans have less than $600 saved for a rainy day. So these high deductible plans that we're strapping them with, and, I think most employers are well intentioned. They're doing the best that they can, but they don't realize that they essentially are uninsured, right? If I can't afford my out of pocket, expenses to access medical care, I virtually have no coverage, right? And
Mhm.
that's what's going on. So they're functionally uninsured. There's a lot to unpack there. So I'm interested in your experience, because you've been doing this for a while. Did you notice, before it was out there in the media, that something was awry with the overprescribing of opioids in your community? Did it pop up? Like, did it strike you as odd that patients now were all of a sudden taking opioids, whereas in the past, it was Tylenol or it was something other than opioids? Or, were you just kind of riding the wave like we all do, and you didn't realize it was a problem until it was a problem?
Well, we were kind of on the cutting edge of that because we worked with one of the largest work comp carriers in Kentucky, and we looked at their patients and the prescribing habits of the physicians. and we saw the high number of opioids that these patients were receiving. And we were ringing the bell early on. And in workers' compensation, it's a different breed. Sadly, in the group health side, nobody looks at that. Nobody looks at, is there overprescribing? Now, I do believe that that has been cut down because of the action that states have taken. In Kentucky, we had a House bill that came through that regulated the pain management clinics, but we would have patients that are on such high dose opioids that they would be receiving what's called, we measure them by morphine equivalence, because different opioids equate out to different doses. And we would have patients that were taking 1,500 morphine equivalents a day. Well, that is like taking, astronomical. The normal dose should be no more than 200 at the most.
Mm,
And that's, you start getting into the area where it's toxic.
right.
And now they're beginning to lower it and saying, no, it should be more like 80 morphine equivalents today should be the maximum.
Right.
So we're finding that toxicity is there.
Sure. And, and I'm sure at that point that's the danger zone, right? I'm no medical doctor, but you don't have to be a medical doctor to know that you're talking about what? 4x, 5x, 10x the recommended dosage. I mean, if truly it's 80 and you're at, would you say 1,500?
Mm-hmm.
Yeah, that's more than, that's near 20x. That's crazy. And
Mm-hmm.
so it's your system, the human body can't possibly know what to do with that. I'm sure you get, and I think one of the dangers or side effects is you risk your heart stopping, right? Amongst, I'm sure, many other things.
Correct.
Crazy. So, um I think there may be some confusion about your role. So, is your job, let's use the opioid example for a moment. Is your job to tell a patient or a member, no, this prescription is much more than necessary, and therefore we are going to intervene and will prescribe what is medically appropriate? Or is that not your role? Where do you kind of come in uh, as that rose between two thorns, if you will? Where does your job start? Where does it end? And are you in the business of telling patients or members what they can or can't have?
We don't, as a nurse, I can't say what they can't have. I can say what they can have. That's part of the utilization review process. If we're looking at a case and it comes in and it meets guidelines, we use guidelines. And if it meets guidelines, the nurse can say yes. The nurse cannot say no. The nurse can pass it on to a physician, and the physician can look at it and they can say, yes, I'm going to allow this. This is close enough to acceptance that I can say yes. That doctor can say no, and then we issue a medical denial. The medical denial goes to the doctor, it goes to the patient, and it has an explanation of what's been denied and why it's been denied. If the doctor wants to appeal it or the patient wants to appeal it, they can do so. It comes into us, and then it goes to what's called a peer match physician. So if the request comes in from an orthopedic doctor, it's going to be looked at by an orthopedic doctor, a board certified orthopedic doctor. He can then have a conversation with the orthopedic doctor, and it's called a peer-to-peer conference. And if the orthopedic doctor maybe didn't put something in his medical record that would have convinced the reviewing physician that it should be allowed, and they talk it over, then the orthopedic doctor can say, yes, it's appropriate, we're going to go on and allow it. That orthopedic doctor can then say yes or no, and that's called a final determination. And that's part of the utilization review process. All of this is within the regulations of ERISA.
Got it. And typically, how long does that loop take to close from beginning to end? or is that just it really depends on
Are
the case?
faster than most entities. We will turn around an initial request within 48 hours of receiving all the medical information. If you submit it to a BUCA, they have 10 days to turn it around, and they usually take 10 days. Frequently, if we get everything that we need on the request, we will respond, and everything's there to say yes. We'll respond on the same working day and give an authorization. On an appeal, it depends when they send in the appeal. We have 14 days to turn around an appeal. By ERISA guidelines, they have 60 days to turn around appeal. We always turn it around in 10 because we like to keep our standards the same as our work comp standards in Kentucky so that my appeal doctors don't get confused. I have 240 physicians that I have on my appeal panel that are different specialists that I can send things to if there's an appeal that comes in.
Mm.
I
And
always say we're the good you are people.
the good
Most
you are.
doctors don't like you are, but we're the good you are people.
So the Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. Reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit benefixa.com. So you actually have a relationship with these physicians, and it's 240 is a big number, but it's also a relatively manageable number. And so, and I would imagine that counts for something, right? Because it's not just you that these physicians are doing, medical review with. It's part of their practice. It's part of what they do as physicians. And so having a relationship and knowing who your team is, I would think, would benefit the patient, just because kind of uh, they understand what your modus operandi is, and that is to deliver the maximum quality care that you can to the patient.
Yes. Our physicians know that we're not asking them for a no. We're asking them for what is medically appropriate.
Right. Right. And so you know, it's really hard for, I think, the average person to wrap their head around how this all works, mechanically, because all of this stuff is happening behind the scenes, right? They're going to their maybe their primary care physician, and the primary care physician is making a referral to a specialist, and the specialist then, at that point, um, is going to suggest a course of treatment. And this happens in a medical plan every day now as well. But how does it differ from a typical experience? And I guess what I'm getting at is, if you were sitting down, at lunch with a girlfriend who really didn't understand what you did, and she was bragging about her Blue Cross Blue Shield or her, United Healthcare, and you wanted to just educate her a little bit. What is the difference between that, patient experience, and one with a self-funded plan that has your service embedded?
I think the big difference is the interest in the employer and caring for the patient and caring for the member. I think if you're a BUCA, I think you care about the cost of care. I think if you're a self-funded plan, while you care about the cost, you care about the member experience more. And I think that's the biggest difference. So with us, we're looking to make sure that the patient has the best outcome that they can have and the best quality experience. We're not going to try and save the plan money at the cost of the member experience or their medical outcome. That
Mm.
we're going to make sure they get the best quality care while saving money for the member and for the plan.
You ever catch any egregious errors? Where someone, um, I don't know, maybe they're prescribed an oncology drug that they shouldn't be prescribed, or have any horror stories?
You know, I honestly don't have any horror stories that I've seen recently. Most of my horror stories would come from, the work comp system where we've just had over overprescribing of opioids, and we've had patients they've requested epidural steroid injections, and then when you look at the patient's MRI, they don't even have a herniated disc, which is why you would do an epidural steroid injection.
Mm.
Well, and we're saying no to those, so we usually prevent those. But every now and then you'll have a situation where a patient's had, you know, 300 chiropractic treatments in, an extended period of time. And it's like, it's not getting any better. Why do you continue to do this? If they were
Right.
doing them periodically, that'd be fine. But, those are the kind of things that we see. Most of the time in the group medical space, I think we have some better selection of physicians by the members. And so we don't see as much egregious activity.
Gotcha. And so are you interfacing with employers, third party administrators, Taft-Hartley plans, all the above? What's your go to market strategy?
We mostly work with third-party administrators and the plans. We don't market directly to employers. We usually market through plans. We do work with reinsurance carriers, but mostly through third-party administrators because they're the ones that have the relationships with the agents and the brokers. I mean, we'll work with anybody, but usually we like to have the third-party administrator be the person that is bringing the plan to us because that's who we're going to be delivering our information to. So we want to, because they're the payer, and we want to make sure that the payer is involved.
Got it. And so what I'm hearing then is your service is really aimed at providing an elevated quality experience for the patient first and foremost, but also in that process, there's a cost savings component to consider for the employer, and if properly designed, employees that accept steerage can actually obtain health care with no out-of-pocket expense to them.
That's exactly it. That's my preferred plans to work with. If members are educated on their options before that time comes, if a member reaches out to us and says, my primary care doctor is going to refer me to an orthopedic surgeon, and then we can say, okay, what's he recommending? And he's recommending that I think he thinks I'm going to need a total knee. Then we can start the process and say, okay, we have an orthopedic surgeon in your area that does total knees. Let's send you there. He can evaluate you and see if that's truly what you need. And if so, we know that he is high quality and he has a bundled price that will give the member, high quality care at the lowest possible cost. And her employer will waive her copay and her deductible because that would be a maximum out of pocket for them.
Sure. Yeah, that's a godsend for folks that are living paycheck to paycheck. My
Absolutely.
mom buried two husbands, and she raised me and my two brothers single handedly. So imagine the single moms out there that are in that position, that are working a job or two jobs to put food on the table, make ends meet, and you have a health plan that has a $3,000 deductible. You can't afford that, right?
Right.
And along comes a plan that has a design which allows that same mother of three to go and have that knee replacement, and do so with zero out of pocket as opposed to a $3,000 bill. That's a godsend. So that's
Mhm.
incredible. How do you vet quality? I hear a lot of folks in our circles throw around the quality, the term quality. How do you determine if one surgeon's quality is better than another's?
There's several different vendors that we use that have done the vetting of the quality, and we can go and look and see how did they do it. And, Medicare and Medicaid or Medicare has quality indexes that we can use and we can look at. Most of that has been done by the vendor. We're not creating these bundles. We're utilizing other places to do that, but we're going back to see where did they get their quality information from. And
Mm,
that information is available out online through Medicare. It's just really difficult to find. So we like to partner with, and this is up to the plan, this is not us,
mhm.
to partner with high quality bundled services and make sure that we're utilizing doctors that do have good outcomes.
Yeah, and the benefit there, for those who are not in the know, you think of, the term bundled essentially means just that, right? So when you go in for surgery, there's a team of folks, an anesthesiologist, a surgeon, a surgical team, you have the facility. If you're in a typical plan and, you go to a hospital, you're basically being billed a la carte. Everything is a separate charge, and often with a bundled arrangement, if there was a complication, an infection, something like that, most often you can repeat that surgery if, God forbid, it was needed to be repeated. And, many bundled providers would honor their original fee, and you would not pay a second fee. Not always, but it does happen sometimes where that would never be the case in a traditional healthcare plan. And not only that, but we know that it's counterintuitive. The highest quality is almost always the lowest cost. So if you have an employer that is partnering with your firm and you're recommending a bundled surgery provider, odds are it's going to be a fraction of what they would pay had they done it in a traditional hospital setting. And so, in the grand scheme of things, I've seen knee replacements for under $20,000. I've seen knee replacements for over $200,000, and it really just depends on the setting. So, as an employer, if you're self-funded and you're responsible for 80% of that charge, would you rather pay 80% of 200,000 or 100% of 15,000? It's not
Yeah,
it's not difficult math.
that's right. That's
Right.
right. And even if you waive, I mean, and that's one of those where sometimes people are like, well, why would I want to just bear the full cost? I'm like, do the math. If you
Right.
just do the math, it works. And it's simple math.
Right, right. We're not talking rocket science calculus
Mhm.
here. No, it's pretty straightforward. Well, hey, this is great stuff. I really appreciate you joining. How could folks find you if they need you?
Well, we have a website and it is medireview.biz. And the reason we use BIZ is because when we first started out, our med one is omca.biz because omca.com was taken by the Ontario Motor Coach Association. So I am I am medireview.biz.
Medireview.biz. Excellent. And medireview.com was probably $300,000.
Yes, probably.
You're like, you know what? BIZ sounds good.
That's it.
Oh, that's great. Well, hey, we really appreciate you coming out today. I've learned a lot. I'm sure our audience has learned a lot. Thank you so much. And until next time, folks, peace and love, peace and love. We'll see you on the next one.
All right, that's a wrap. Hit like, follow, and subscribe, and we'll catch you next time.